Hello everyone, and very welcome, warm welcome to NISCC's lunchtime seminars. This is one of a series of seminars. We have one more in March, and we try to focus very much on practice or research or thinking that will support registrants and professionals out there in the field. So you're very, very welcome today, and we would ask you to consider, because there will be an ongoing calendar, so please spread the word if you find this enjoyable. We have a very distinguished speaker today, Kevin Moore, who's going to come and talk about his research around exploration of the roles and responsibilities and services provided by home care workers in a large health and social care trust. And I have heard Kevin speak very elegantly at Stormont on this particular subject, and it's a very enjoyable seminar, and he will speak for 30 to 40 minutes. Afterwards he will welcome any sort of discussion around his findings. So without further ado, Kevin.
Thank you, Paul. Good afternoon, folks. Thanks very much for coming, because I appreciate you're probably all very busy and in the run up to Christmas. So Paul's already given you an indication of how long I speak for, and I'll try not to extend that too long, because there's certainly one thing that I know how to do, and that's to speak, or as they would say in Northern Ireland, to speak. So I'll do my best not to keep you too long. What I'm going to present today is the culmination of 6 years of work, or probably what I really should say is 6 years of torment and hell, called a PhD for those of you who've ever done one, and a big long dark tunnel, and I've come out the other end. But I'm very passionate about what I've done. I'm very passionate about the work, and I want to acknowledge the funding that I got from the trust, one of the trusts here in Northern Ireland, to do this work. Just so that you understand, in terms of home care services, you'll understand that home care services were envisaged at the establishment of the National Health Service way back in '46 by Anya and Bevan, and their vision at that stage was that it would be indeed a cradle-to-grave concept, and that's something that's still enshrined in terms of what we do, and equally so, unfortunately, then that sort of concept of younger and older clients and our increasing demography provides the challenges that the service is attempting to meet today. In terms of the work, the background to strategic drivers, everyone's probably, if you've ever attended a seminar recently, you're aware of the challenges of a growing older population, our demography, our challenges specifically, not just here in Northern Ireland, but equally nationally and internationally of a growing older population. And we must not necessarily always see that as something that's negative. Oh dear, we're growing old, and that's something negative. A growing older population has many challenges. Government legislation, transforming your care, HPSS regulatory frameworks, the HPSS standards for domiciliary care, the role and input that the government plays in terms of providing strategic drivers for reform of our National Health Service. And the RPA, which sounds probably like a distant sort of thing in the past now, review of public administration, and I see now some rumblings again that we're looking to review again our strategy and our deliveries. Tied into this as well is obviously how we provide care in terms of rural care and our rural populations. There is a dearth of published material on the role of domiciliary care right across not just Northern Ireland and the UK, but from a European perspective and also from an international perspective. There are some longitudinal studies that have been conducted in America, and there was one huge study that looked and compared 18 different European countries, the Living at Home Report 2011. And one of the conclusions within that report is that each of the countries primarily deliver this type of care depending on the specific market economy within the country. And there was quite a wide diversity within that, and indeed quite often many of the services were responsive, are responding to an increasing need, but not necessarily being strategic enough in terms of forward planning for population growth. So when I started the journey, we wanted to look at a decent, robust piece of work that would stand up obviously to scrutiny and they would have a doctorate level of study as is required to pass the PhD first and foremost, but also in terms of the rigours of the work. And so I utilised a theory, it's called grounded theory. Why grounded theory? Grounded theory because it helps us to look and explore an area where there is little work or little theory development within it, and it helps to guide us in terms of what we're doing. And there are various core components of a grounded theory approach. So we talk about constant comparative analysis, and really what's involved with that is you go into an area and something arises. And I'll give you an example of the very early stages. I went into an area and I met with a home help who didn't drive, but owned a bicycle, and she reported about 15 to 20 extra hours of visitations every week in the trust that she was working in. And I said to her, well, why do you do that? The woman's name was Mary. She's deceased now, God rest her. And she said, well look, she said, they're part of my extended family and I've been doing it now for so long. And so you try to tease that out and look at what it is she's doing it, why she's doing it, when she's doing it, what circumstances she does it, etc., etc., what is it that she's doing. And it became very clear at the very outset that it wasn't always necessarily motivated by pay. So you lift that idea from that area, that one person, and you try to challenge it then again with someone else, basically, and to see are there other people willing to do the same thing, or are other people doing the same thing? Do managers know that this is happening? Why are people doing this? What motivates them? And if you do that, then you can carry out a constant comparative analysis of what's going on, and then you start to develop basically a category or a theme or a subject that is worthy then of a further investigation. And unfortunately then you have to keep moving. So then you move then with theoretical sampling. So rather than saying I'm going to go to place A, B, C and D, you try to decide where am I going to go, where I can get this information best. And when we started this project, the review of public administration was very early in its stages, and we were sort of put on the back burner for about a year and a half, and we had a naive interpretation that we would do 4 different groups of home helps and domiciliary care workers across the trust. And really, when you see the amount of people that I had contact with, you'll understand then why it's important then for the third thing, which is the theoretical sensitivity. You get very sensitized in what you're doing, speaking with people. Very quickly I picked up on that there was a difference between an urban area and a rural area. There was a difference in some home health and domiciliary care workers. There was some differentiation in terms of age. The more mature members who had been working for a long period of time, and how people interpreted things and their perceptions and what motivated them and what they were willing to do and what they weren't willing to do. And then some younger people who were coming up, and then in a contrast between, for example, formal qualifications and the lack of formal qualifications vis-a-vis experience. So all of those things start to come into this myriad of a grounded theory approach. And you end up, which I did end up with, something like 148 pages of diagrams with subcategories and sub-themes, and you're trying to wrap your head around it, and trust me, it can be quite complex, and trying to stand over it. And then to have a phrase or a statement. So what I'm going to try and give you today is a flavour of that, and the best way that any researcher can present what they're doing is give voice to the people, so it's their voices. So I opted for a 2-phase study, qualitative and quantitative. And indeed, it's quite a new approach. Many people will have deployed a quantitative approach and design a questionnaire. And indeed, if you look at many of the questionnaires that have been done in health and social care, particularly with this greater worker across the United Kingdom that have been supported by the Department of Health, response rates are appallingly low. So you're talking about 8 and 12% for some of these large groups of staff with questionnaires. And despite their best efforts, they still fail to get a significant sample of people to participate. So I started off with a qualitative arm where basically everything was up in the air. I had a few core questions just that I asked. And I started using focus groups, semi-structured interviews, and I've added to the theory of grounded theory by Strauss and Corbin by conducting a community forum meeting. And you might say, well, what on earth is that? Well, we told people that we were coming, that there was researchers coming, in a small rural area of County Fermanagh. And I arrived and I came into the room and I thought, where on earth are all these bloody women going? And I was standing and I was shuffling in with these women. I said, what are you all here today? She says, there's somebody coming, she says, to do research, and we're going to give them a piece of our mind and let them know about our job, because nobody's really ever asked us before about our job. And I thought, God, I'm not going to tell this woman that that's me. But there was about 48 or 50 people in that room. Such was the interest in talking to someone about what it is they do. And but for every researcher, as you can understand, that's a nightmare. You can't sit down your tape recorder and start recording when there's about 10 people chatting at once, particularly in a rural area. So I did that. What I then did was I lifted that information as best I could and formulated it into core areas within a quantitative approach. Because, you know, some researchers will say, like, you know, qualitative approach, it's very subjective, you extract from it what you want. It's better to have a quantitative approach, and we're all into numbers and quantifying and statistics and SPSS and all the rest, and testing the theory. So I developed a theory, a substantive theory in health and social care, and then I tested that theory. And I thought it would be quite easy to develop a questionnaire, but for those of you who've ever tried to devise a questionnaire, you'll also understand it's not something you do in 5 or 6 months. It took me roughly about a year to develop the questionnaire, and to get it right with something like 6 pilots, including going down south to get a totally independent group of people doing like-minded jobs in a private sector. So our data collection in phase 1, which was the qualitative phase, I ended up actually holding 11 focus groups right across the trust and had access to a total of 128 staff. The semi-structured qualitative interviews then with senior managers, I wanted to keep them separate simply because in the very early stages of one of the groups I actually had supervisors with home health, and I very quickly picked up that the presence of the supervisors was an inhibitory factor for the home health being able to complain about the supervisors, basically, or talk about the role of supervisors, and etc, etc. So we tried to keep those separate. I've told you about the community meeting, and unfortunately for me, I ended up having to try and write as best I could and drop memos and field notes and pages, because that lasted about 2.5 to 3 hours. Such was the volume of things that they'd wanted to say. So in total in phase 1, I had 179 participants who expressed an opinion. One of my interviews, for example, with one group, sort of 45-50 minutes, just so you get an idea of the voluminous amounts of data, that ran to about 45 or 46 pages of a transcript of A4 type. What I can also tell you is that the people in the country, rural people, always had much more to say, and those transcripts generally were about 50 or 60 pages long. And I'm very mindful of one of the areas that I went into, which was in Greencastle, County Tyrone, and we were talking about roads, we had very, very bad snow at that stage, and one of the women on the tape turned around and says to the other, she says, "Come on, Brady," she says, "we better go," she says, "to Paddy." She says, "All very well sitting here chatting to your man," she says, "but you know damn rightly they'll be chatting about you and me in the post office if we don't get out to him before lunchtime and get him his lunch." And that just so epitomised what it was they were about in terms of their care. And it was snowing, it really was snowing outside, and it was quite a bad day. So those interviews were all recorded and transcribed verbatim. So you're left with a voluminous amount of transcripts and data, trying to make sense of it all. And suffice to say, it could do your head in a wee bit. But anyway, how do I manage that? So I have various ways, and I'm trying not to insult anyone's integrity who may be a grounded theorist. And trust me, I treaded very carefully over 6 years of the people who were supervising me not to insult their integrity. And I found wonderful ways of making it simple. And I chose 2 analogies to help people understand what I did with the data. And one of those is a jigsaw. So you might go out, and it's coming up to Christmas, and you might buy a jigsaw, and you see what the jigsaw looks like on the box before you buy it, and you buy it because it's aesthetically pleasing or you like it, and you take it home and you open it, and there maybe is about 2,000 or 3,000 pieces inside the jigsaw. Then you set about reconstructing those pieces. Some of you will start with the corners, some of you will start with the straight edges, some of you will start with colours, the green, blue for the sea, blue for the sky, whatever, brown for the sand, whatever the picture happens to be. And you'll construct it in segments, and in pieces until it equals the whole. Ground theory and open, axial and selective coding is not dissimilar to that, in that you're looking for groups and clusters of things, core categories, and within that you're looking for subcategories. Then you're looking for thematic interpretations in a subcategory, and then phrases that link to that there. Another way to look at it, quite simply, and Strauss and Corbin used this analogy themselves, is an umbrella. And we're all familiar with what an umbrella looks like, and we put it up when it's raining or when it's snowing or whatever. But think about an umbrella. An umbrella has a cover, which is its primary purpose, to provide protection. But in underneath that umbrella, there are multiple spokes and connections connected to a handle and a central frame, right down into a handle. And grounded theory is very much like that. You really want to reach the handle, the level of understanding, the substantive theory. But everything that holds this is supported by a wider network of things that come together. So really, that's the easiest way that I can describe this process of taking the data apart and subjecting it to interpretation and understanding. And when we're doing that, it's not just my interpretation. You independently will give a transcript to someone else and ask them to have a look at it to see what they come up with. For example, one of the core categories that came up was altruism. And one of my transcripts was looked at by Professor Jennifer Boer. And she started to scream at me that this was a major leap in understanding. How could I say that this was altruistic? How could I even say, and this was another argument, that home care workers were professionals in their own right? How dare you use the word professional that don't have qualifications? And on the story goes. I also then brought the transcripts out and interpretation to groups of people who had participated in the study and said, look, this is what I think you're saying, what do you think? And given them a chance. So that takes you in there to Chiavatti and Pirani's model for grounded theory, checking the theoretical construct against participants' meaning of the phenomenon. And you know, it's a nice wee reference and it's lovely, but there are 8 complex interaction stages within Chiavatti and Pirani's model. And the other thing, for those of you who've done research and you think that computers are wonderful, and they really are, and I thought in vivo, this is great, feed my transcripts in and it'll throw out the analysis. What a load of nonsense. It'll do absolutely nothing for you except store the data, and it's really a data retrieval and management system. You can find things like an edit find, so you'll find the concept of caring, so you could search for it and it'll extract a piece of a statement that somebody made. Other than that, I didn't find it particularly useful. This is the model. Not going to spend any time on that, it's just that you understand that this model enables you to analyse your data when you take it all together. And this is the basis of grounded theory in accordance with Strauss and Corbin and Strauss. So, I developed the core category, which is the centrepiece of the model, which is my substantive theory. And that was that there was a disconnect between the perceived centrality of the role of domiciliary care staff and the recognition of the importance of this role within the wider health and social care community. There was clearly no illusion with respect to these staff in terms of the role that they fulfilled and how they fulfilled their role on a day-to-day basis, and how they interpret their role and the meaning and attachment of that role. However, when it came to their role within the wider health and social care community and the wider health and social care context, there was a significant disconnect in terms of the perceptions of the role and the role that they played within wider health and social care. So, I looked at my findings in 6 core areas, i.e. the location of care, the characteristics of domiciliary care staff, caring itself and their caregiving relationship, and then 3 core areas: role identification, role challenges, and role conflict. And these 6 areas here then were further distributed within a quantitative questionnaire that was sent out to the entire trust staff to enable us to say, well, yes, look, this is supported by this, or this is supported by that, or whatever. So, to give voice, location of care, you do understand that my next door neighbour might be 4 or 5 fields away. So I do the things I do because I care for my client, who is, after all, my neighbour. And indeed, whilst they might live miles from me, I see them and theirs as an extension to my own family. Come on, Brady, it's all very well, and I've already talked about this one, talking about this to your man here, but if we don't get on with it, they'll be talking about you and me in the post office. So the location of care became very important very early on, and the things that some of these workers did in rural communities vis-a-vis urban communities, and the interpretations that they attached to it. Indeed, some of the workers in rural areas perceived it as an extension or a core component of their role, whereas some of the younger staff in some of the urban areas thought that it was something crazy that you would actually go to a chemist and pick up a prescription for someone. Why would I do that? The kind of family to do that. Whereas Mary might have got on her bicycle and done that for someone else. It was rather strange. So the identification of role, helping to give choice, respect, listening to what they've got to say, I love my job. Knowing that I make a difference to the quality of my clients' daily lives, making them so happy, I feel valued and trusted. It's the interaction with the clients, the relationships you build, and the support of the team. It's such a worthwhile service. Challenges. I feel that this is a very stressful role job, and I personally feel that I'm not delivering the quality of care. It's upsetting, really. It takes too long when you report to a supervisor for additional help or equipment until it appears. It's upsetting all around. Now, there were many role challenges, particularly some role challenges at the interplay with other healthcare professionals, for example, district nurses, GPs, social work assistants and social workers. Those presented them with many challenges. Conflict. You can see here there was internal role conflict for those who were employed as home health, exclusively as home health. And this trust was trying to diminish that role and get rid of this role. I'm here to do personal care, not home health. And if you need those services, well then see a social worker. The roles are becoming closer now. Home helps are being trained to do personal care. And indeed an analysis of the job descriptions didn't really show much of a differentiation in terms of roles, other than certain things were prioritised within the job description higher up and less lower down. We're now getting hounded over sick leave and overtime, as every week somebody is off on sick leave. There was a significant degree of conflict within roles and across roles, and particularly where there are elements of multi-professional or multidisciplinary working. The characteristics of their caring. I like working with elderly people, and I feel they have good life experiences, especially in respecting sick and vulnerable people. Caring for clients and knowing that I've made a difference to their overall well-being is important to me. Giving my work 100% is important to me. I'd always go over and above and call of duty, and this doesn't bother me at all. It's who I am. They're caring. Because you're doing personal care, washing and dressing, that doesn't mean that that's all that has to be done, nor indeed is it all that they would ever do either. Plus, when you're dealing with the same patients week after week, you can monitor their progress and see if they're okay or if they're feeling depressed. We basically become part of their family too and care for them like our own. Everybody likes their own wee corner at the end of the day, and if there's enough good positive care provided by us in the community, well then it'll stop them from being shipped into a nursing home. And I can assure you that our previous health minister was exceptionally interested when I presented some findings at the Derry City of Culture conference, particularly because this helps to aspire to some of the aspirations within transforming your care and keeping people at home and enabling services in a locality that will facilitate that process. So we looked at those things and we developed a postal questionnaire to all the domiciliary care staff employed within the trust. When we started, there was 1,082 staff. By the time we got to the questionnaire phase, the staff had reduced, there were 734 staff. So we got a 42.8% response rate, which is quite high, although there are some statisticians would say, well look, you still have 58% of people that you don't know anything about. But there are at least 3 or 4 major studies that have been conducted across the UK, within Scotland, England and Wales, and their participant rates are very, very low in comparison. There are some studies here in Northern Ireland, and they had some response rates up to about 24%. The questionnaires were analysed using SPSS, and response rates did compare favourably with similar research in Northern Ireland and the UK, and indeed across America. One of the things that I did as part of the study is I actually went out and spent over 2 weeks with home care agencies and the international market out in the United States in Michigan. and it was rather interesting. And as you well know, I'm sure there are many pessimists about the National Health Service here in the UK. And so I would suggest you say to them in future, if you don't like our National Health Service, and a lot of people don't, drop them off somewhere about America and then they'll know what it's all about. And they'll not just be as critical. Because for older people living in some of these private areas, if their money runs out, they'll steer them towards the door and then they become the responsibility of the state, quite simply. And one of the areas that I went to was absolutely astounding. The place was beautiful and it cost serious megabucks to be there. But I said to the woman about the incidence of what we call pre-senile dementia and people living longer. So I could go into an institution like this or a home like this or at 45 years of age and I could live till I'm 98. My money's bound to run out. And I specifically asked them what happened. She said, well, we sort of politely show you to the door, which was a bit shocking. And I said, have you ever done that? She said, yes, twice. So, postal questionnaire. So, the majority of respondents, 99% were females. That should be no surprise. And that's representative of the demographic right across the UK, of whom 75% were married, with only a small minority were single, divorced or widowed. The age profile, which is a worrying statistic, ranged from 21 to 77 years of age, with the mean average age of 52.27. We shouldn't be surprised at that because our government will have you and me working probably to we're 87 by the time we finish, never mind 77. And this woman at 77, by the way, she worked about 42 hours a week. I remember, as clear as a bell, she had put some of us to shame. However, what we need to look at here is a significant number. We're over 60, 23.8%, and a very small minority under 30 years of age, 1.8%. So the challenge is, where do we get these workers from? How do we attract workers into this area? And who on earth is going to look after us when we're 77 and 87? I sincerely hope it's not some of the students that I'm currently training, because they'll probably slap me along the back of the head for giving them a hard time as they train. But anyway, over 50.8% of the total respondents were employed within the trust were over 40 years of age. Now those are significant demographics, but they are also representative of the demographics within health and social care, and you're aware of some of the major reports in terms of manpower and strategy planning, not just within the DHSS-PS, but across the DOH, Scotland, England and Wales. Discriminant analysis using the SPSS indicated that domiciliary helps tended to be much older, 56.42, compared to the domiciliary care workers. Their mean was 50.65 years. Qualifications, again, this is sort of something that's mirrored right across the board. NVQ level 1, you can clearly see here in terms of those that held an NVQ level 1 was only 7%, and 92.7% didn't hold formal qualifications. The NVQ level 2, some seem to be a bit better, 52% held an NVQ level 2, 7% level 3, and then when we went anything above, which would be a certificate in health or health and social care, degrees, postgraduate diplomas, again, it's not a great picture at that extreme end where 7.3% are holding formal qualifications. When we looked at the discriminant analysis of the length of time worked, the hours worked weekly and the clients that they visited, the trust was certainly exceptionally busy in terms of the total client contact hours and the amount of hours that staff were working. And you can see here that on average the length of employment for domiciliary care was 13.6 as opposed to 18.8 for the domiciliary care workers. On average, the domiciliary care workers worked 24.6 hours per week and visited over 22 clients. Now those are not necessarily contacts, those are specific individual clients. So the same client, for example, could have been visited more than once. There was something like in one period, I can't remember whether it was a weekly or a month, there was over 5,000 contacts. So we looked at contacts separately but haven't gone into it here. Prior experience, why are these people coming into the post? Extension to a caring role, you can see that was actually quite high. Many of these were women who had now got their kids off to school and had a bit more time, or had cared for a sick relative, a dying mother, a sister who had cancer or something like that there. And so that motivated them to feel that they had something to offer in working with older people. And that was very high up the list. And you can see there then when we look at the figures in terms of terms and conditions of employment, and prior community experience, promotion, etc., etc., asked by a neighbour to fill a gap, those types of things. So I think those are important if we're going to try and look at how do we recruit people to the roles. Location of care, again, we looked at whether people were primarily delivering care in an urban, rural or mixed area, and there's a bit of a mixed bag with respect to that in terms of the urban. So some people primarily worked in an urban area about a third of the time, and then when they come out into a rural area, a larger amount of people, but that should be no surprise in terms of rural aspects of healthcare in Northern Ireland. Working patterns, in terms of capacity, this was something that even the Trust weren't familiar with, which was found quite strange. Staff were employed in more than one grade with different terms and conditions. They were either employed as a home help for certain hours or employed as a domiciliary care worker for other hours. And that didn't rear its ugly head until we were out trying to collect the data. And you can see here the total numbers of people who were employed in more than one position. And you can see then when we look at capacity, those that definitely don't work weekends, 85%. Those that work evenings or those that work nights, the figure slightly off, there's about 22%. And again, there's capacity within that there if we're looking at a 24-hour service across the board. Quality of care is interesting, it's very important. People perceive the quality of care that was being delivered as actually excellent or very good, which is important in terms of what they were at. And even though they had a significant degree of criticism, and we'll come to some of those points in a minute, about the type of care and the level of interaction and the conflict, they still felt on whole, even with the core issue, and their core issue, by the way, was, guess what, which was time, and time to do the skills. They still felt they delivered a quality service. We asked 100 questions in the questionnaire, and when I devised the first questionnaire, it was 14 pages long and had over 200 questions, and it took nearly 2 hours to complete. So you can imagine as a researcher you couldn't go out with that. So 7 or 8 months later, with 6 or 7 revisions and multiple pilots, we got it down to 4 pages, 2-sided, which was 8, and 100 questions. Questions 98 and 99 basically said, tell us something, 3 good things about your job, 3 things you'd like to change. And question 100 was, is there anything that you think we haven't asked you that you'd like to tell us? Now, you would hope after something like 97 questions there wouldn't have anything else to tell you. Can I assure you that with questions 98, 99 and 100, the analysis ran into 400 and 500 pages of data. So much so for question 100, one of the questions, we ended up having to get another programme to analyse the themes of what was actually being said. Some people wrote essays nearly in the back of the form and continued on. Whether that was a challenge to the design of the questionnaire, and we tried to quantify it a wee bit, but getting that qualitative data was critical to us. It really, really was. But it also spoke about the motivation of the staff group. Core things about their role they wanted to change. Let carers have an input with risk assessments and care plans. Many staff found it incredulous that care plans were changed or indeed were in effect put in place in the absence of someone visiting the actual client or consulting with them when they were actually visiting the client. Spot checks, which was an interesting one to be carried out with supervisors to ensure that all carers are providing care adequately. Interestingly, the supervisors posed the specific challenge in terms of they felt they couldn't undertake the supervisory role because they were more and more desk bound, but were very aware that in some instances the standards of care weren't particularly good. More cover for sickness and especially at weekends, more hours, more time with clients, and not to feel rushed in the performance of my job. Less recording. I would like to become more involved when care plans are being allocated or changed for my clients. Cutbacks. As the role we provide in the home and to the client is valuable as people are now living longer, they felt that it was difficult, and in many instances, and this is probably like a lamb coming into the lion's den here, they were very critical of social work assistants and social workers, and indeed there were multiple statements written about, I would like the social worker to come in and try to do, and they listed 4 or 5 things that they were asked to do in the time that I have been given to do them. some instances 15 or 20 minutes, and you heard things like, you know, my social worker obviously has never boiled a saucepan of spuds in her life, because she wouldn't ask me to come in and get Brady out of bed and boil a saucepan of spuds and light the fire in 15 minutes if she did. Those are the types of comment, and that's only a snapshot, and I don't want people to start shouting at me just already. Being recognised for the job that I do and paid for same. Pay was a core issue, but not a fundamentally core issue, by the way. Working with uncooperative social workers and being taken for granted by clients and family, there was a significant degree of conflict within certain families, particularly in some of the urban areas where they felt, in some comments, where I feel as if I'm treated like a skivvy. And the primary care makes me do things because I have 20 minutes or half an hour to do it, and I'm damned if I'm going to get out before the half an hour is up. They'll make me do things. And one of the instances, the most demoralising thing one of the workers was asked to do, she had to pull up some woman's stockings in the house because they'd fallen down for the second time while she was there, but yet there was a primary carer there just because she wasn't allowed to leave before the time was up. Recommendations. A training needs analysis. There was what isn't captured there, there was a 97% uptake of in-house mandatory formal training within the Trust. All levels of training, there was a 97% uptake. But that training isn't necessarily linked to a strategic framework in terms of an NVQ framework or anything like that there. And so there's a need to ensure that what is it that we want this staff to do? What is it that is the minimum expectation of the qualification that we want them to do? And how then do we put those provisions in place to ensure that it can be recognised and appropriately accredited so that they become part of our wider health and social care team and they're recognised for what they do. They very much reminded me of work when I started looking at Jolly and Allen in 1979, and she posed the question, which was, is nursing a profession? And should nursing become research-based? Now you might sit there today and think, good Lord above, how could any health and social care professional operate in the absence of an evidence-informed approach or research? But let's be honest, in the early 70s, it wasn't there. And how significant that is. And I see that this are a group of aspiring staff that will create greater momentum as we move. Training and support mechanisms must be inclusive of client assessment and client evaluation. I am not standing here to say that they must, on all occasions, be involved in assessment and evaluations, but at the very least, there needs to be involvement or consultation in terms of their input and what they're doing. Domiciliary care staff involved in assessments and care reviews. I don't think that that's too much for us to ask, particularly if they're spending 14 or 15 hours with person A or person B in a given week, particularly if care is being changed. On some occasions, care packages were changed and nobody came to the home. The person got a phone call to say, your hours have been cut, and the first person in the front line then was the home health, the domiciliary care worker, who was getting shouted at by either the carer or the family. Continued monitoring of the impact of domiciliary care on an older adult's meaning of home and its potential impact on their recovery. Clearly there is work there by Assumpta Ryan that clearly demonstrates it, and I'm sure that each of us in the room would agree. I want to be at home. I certainly don't want to go into a nursing home, and I've seen some lovely homes and some lovely sheltered accommodation. It's not for me. So why shouldn't I be enabled and facilitated there? And that transition from home, my home, to another home is a complex one. But there are also advantages for people who are living with isolation and loneliness and the comorbidity issues of depression and mental ill health, and how these people can then, their lives can be changed by living in a nursing home or living in a residential or a care unit. Clinical supervision and the supervisory support arrangements must place value on the role of its domiciliary care staff. There's a need for valuing of the role in terms of its recognition. Complex client assessments for home care must be underpinned in a collaborative and collegiate manner using the Northern Ireland Single Assessment Tool as an approach. An evidence-based approach, longitudinal studies advocate the use of the tool, and I know that there are significant disadvantages with respect to it, but if we're challenged in terms of how we provide things and why we provide them, we have to have some basis that underpins the approach. Quality assurance mechanisms must extrapolate on how domiciliary care workers experience and negotiate their work on a daily basis. Stacey, for example, in 2005, a large longitudinal study in the United States of America clearly articulated that home care staff give dignity to dirty work. And that was their firm conclusions. This group of people, generally women, underqualified, poorly paid females, give dignity to dirty work. And there are similarities with respect to our UK workforce. So how do we effectively respond to staff needs and compliance with legislative and regulatory frameworks? And indeed, I have already met with the Commissioner here for older people in Northern Ireland to explore and extrapolate on the domiciliary care standards and the role for home care workers within that framework as we move towards registration, regulation, etc., etc. The integrated service delivery model must be implemented as a priority for effective service delivery. This one was a core one. Home care for the older person must be based on reablement. And you'll see that this word is being used much more often within health and social care. At the point we were looking at a research, there was one person employed in that role. The evidence from longitudinal work carried out in the UK from Jones et al. Talks about the need to ensure that we understand what reablement is. And they have some very effective reablement models, very well in place in some large health and social care trusts that gather their evidence to inform their approach and critique the evidence as a means of informing and developing how reablement works effectively. And in those models, clients are coming in and they're prescribed a certain amount of care for a specific period of time, and it's time bounded and then it's reviewed. Whereas some clients come into our caseloads, for example, and in these caseloads in this trust, and they're there forever more men in a day. You will have heard the Health Minister clearly talk and indeed transforming your care. Home is the hub, page 10, it's quite emphatic that the home is the hub. Intercollegiate, multi-professional, multidisciplinary working, but the home is the hub. The difficulty with that assertion is that what is interpreted as home needs a clearly defined operational definition, because home for me might be a nursing home. Home for me might be a residential unit. Home for me might be in the private sector with apex housing, with sheltered accommodation, etc., etc. So it's not just quite simply saying home is where we were reared or where we were born or where we grow up. Implications. There are significant implications in terms of how we deliver our care, particularly where we have a rural population. And Stockdale in 2009, and indeed Deirdre Heenan, who sits in some of the government committees at Stormont, will clearly identify the challenges in provision of rural health care. The core issue of isolation and loneliness, and how those factors contribute to poor mental ill health, and the significant increase then on poor ill health in our rural communities in terms of access, is a significant challenge to health and social care. So health and social care provision at an organisational level with appropriate responsiveness training, and that's something that we will have to embrace with our healthcare workers, the domiciliary care workers. The caring trajectory is one of the significant challenges for the client with the concept of caring. I have postulated in my work, and I've already published this work, that the care workers, the home care workers, aspire many core components of a person-centred ethos that is clearly evident within the professional literature. Some of the work within, for example, in social work by Rolf, within multidisciplinary, multi-professional, collegiate working, will have identified the core components of team working. Within these groups, there are elements that are clearly present that indicate that this is a group that's willing and ready, but not necessarily yet enabled to move forward in a positive way with working. So therefore, the continuity of caring within a person-centred practice framework is something that we mustn't lose, because they're a very highly motivated, altruistic bunch of people who are very willing to embrace these challenges. So therefore, how do we effectively respond to the process of change? And that's a challenge within all large organisations, with an effective model that underpins effective practice. And that's going to be a significant implication. So therefore, my concluding comment, I spoke really long, haven't I? The effective management of domiciliary care services for the client and their family have the most significant ramifications, insofar as the current, and this is the most important thing, the excellent standards of domiciliary care must be harnessed, really further identified and managed with effective quality performance indicators. Community nurses and other health and social care staff working collegiately with domiciliary care staff can enable, facilitate and nurture this process within existing professional relationships. And that's a challenge, and there's significant pieces of work written within your own disciplines of social work about multi-professional and multidisciplinary working and how we bring that together. And we have the same challenges in nursing in terms of how we work with health and social care and definitions of terms. I mean, you have healthcare assistants, you have nursing assistants, you have healthcare assistants band A, band B. What is their role? Role extension, role elaboration. So those are the challenges, and I think that this staff group, the domiciliary care staff, the home care staff, are already in a position to embrace the challenges, but how we as a group of healthcare professionals manage that as we move forward in responding to transforming your care is going to be the most significant challenge, particularly if the disconnect becomes a rift and not a disconnect. Thanks for listening.